Good morning. Can the folks online give me some indication that you can hear okay? We're good? All right, fantastic. All right, so let me move this out of the way. Thank you all for being here. We have a small crowd here in person. Thank you for those who can make it online. Looks like we have a few. Just before we get started, I'm the director of the Claude Pepper Center. We're really honored to have two people from the University of Minnesota's Health Policy and Management department from the School of Public Health, College of Public School. I had it right.
It's a college.
Sorry, School of Public Health. We have long admired the University of Minnesota's public health school with a variety of different kinds of innovations that I think you lead on, and I think we can learn so much for our university. Today, after we finish with Dr. Shippee's talk, we'll also have a few minutes to visit here. For those of you who are online, please don't hesitate as things come up. We have someone who's available to collect your questions, so we can be sure to get them to him, either during the talk, if you want us to interrupt him to clarify, just feel free to let us know, but at the end we'll have plenty of time for Q&A. So I want to start by just giving a warm welcome and introduction for Nathan Shippee. So I'm touching the microphone here, I apologize. Nathan is an associate professor in the Division of Health Policy and Management, and he's a healthcare delivery researcher. So his work has focused on how healthcare payment and delivery systems address complex needs surrounding chronic disease, behavioral health, and non-medical complicating factors. He's done a whole variety of different research studies across a variety of topics, but he has actually spent the last couple of days teaching us a lot about very interesting and important work he does to help facilitate research in others too. So we have a person here with phenomenal knowledge and understanding of how to help users who want to work with things like Medicare data and integrate it into their work so we can get better sense of a whole variety of ways in which individuals age over time at all ages. So one of the areas that I wanted to point out is that Dr. Shippee's work is funded by a whole variety of sources, including the Robert Wood Johnson Foundation, the Commonwealth Fund, the National Institutes of Health, and his ResDoc work is through CMS and AHRQ. He has research that's been funded by the Patient-Centered Outcomes Research Institute, and then of course also does lots of work with state and county agencies and other health systems. So I'm gonna let him kind of take it from here and kind of describe some of this and how it works and how he got to here. We're really pleased and honored to have him here, and thank you so much.
Great, thank you. Thanks for everybody for showing up in person and online. Well, I think that was a good enough introduction. I would just say that I list a couple of titles here. So the first one is the Research Data Assistance Center. I want to give a plug for that because that's a lot of my work right now. That's ResDoc is a CMS contractor that if anybody's using Medicare, Medicaid, or say assessment data for things like nursing homes, they're probably going through us to obtain those data. So we provide a support function in obtaining those data. That's going through kind of the application process to form a data use agreement with CMS for these pretty sensitive data. And then on the back end for people, once they've obtained the data, we also assist with data use. So we do things like provide 4 workshops a year on the different CMS data sources, including Medicare fee-for-service, encounter data for Medicare Advantage, Medicare Part D, and Medicaid, what are called the TAF, newer Medicaid files. So we provide those workshops. We run a conference booth where we say hi to people and take some questions and things. And then lastly, we also have in-house analysts and technical advisors who help to answer lots of different questions with people finding things that are maybe unexpected in the data or that they don't quite understand, as they are a pretty complex data source. The other thing I just want to give a plug for is the Minnesota Learning Health Systems training program. This was originally funded, well, it's still funded by ARC and PCORI. That is it's a training program that started out as a K-type training program, where it was originally a partnership between the University of Minnesota, the Mayo Clinic, and Hennepin Healthcare Research Institute, which I'll talk about in a second. Mostly oriented toward scholar training for early career faculty. And what it really focuses on is the kind of newer paradigm of learning health systems research, which is, it's got a number of different domains that you can find. ARC lists these domains around system science, stakeholder engagement, things like that, so that we can move projects forward in a practical manner and in, kind of obtain research findings that are actually actionable and implementable. That has since been moved to a different, it's a P30 mechanism now, a center mechanism, and so, but we still have the same training program. So I've been with in the leadership of that program since 2018. With ResDec, I've been there since 2014, I think, and I took over as PI in 2022. All right, so for an outline today, I kind of want to approach things maybe a little backward. If you see some talks maybe start with kind of background and theory and then move into an application. I want to start with a specific research application, which is the evaluation of the Hennepin Health Medicaid ACO and lessons learned from that, and then widening out a little bit to concepts and theory. So the context of the Hennepin Health model was Medicaid expansion, and particularly early Medicaid expansion. With the lead up to the larger Medicaid expansion in 2014, some states expanded early. Minnesota's early expansion, which replaced some state program coverage and also added some never covered enrollees, was for individuals under 75% of the federal poverty level. Even compared to the larger Medicaid expansion at 138% functionally, this is really what we've, in our internal terms of teams, have termed clinical poverty. Because it really touches everything about this population. To give some context, 75% of the federal poverty level would have been about $8,500 a year in income in around 2011, 2012 period. Minnesota's early Medicaid expansion enrollees face high rates of interlocking challenges. Most of them experienced homelessness, major mental illness, and/or substance use. About a quarter had at least two of these, and 10% had all three. And I would note that these are coming from claims and administrative data, and so it's highly likely that these are seriously undercounted because this population has really poor access to care, and I can give an illustration of that. So these are months enrolled in Medicaid per year. And I just want to draw your attention to the bottom bar, which is this early expansion population. Out of a given year, on average, they were enrolled for about 6, maybe 7 months, compared to a lot of other eligibility groups, which are closer to 9, 10, or 11 months at least out of the year. So even among Medicaid, which is a population that is characterized by fairly frequent disenrollment, the early Medicaid expansion population was in particular undercovered during the time when they might have been eligible. All right, so the Hennepin Health Accountable Care Organization, this is a Medicaid accountable care organization. I'll talk about what that means for the design of this model in a second, but it's located in Hennepin County, which is Minnesota's largest county. It's the county that contains Minneapolis. It's also a county where a lot of services, including healthcare and social services, are really concentrated, and therefore it kind of becomes a magnet for people who need those services. So you'll hear in some of our qualitative work, we would hear stories about people who started out in a smaller city or town like St. Cloud, which is a little bit farther north in Minnesota, and then had kind of ended up moving toward the Twin Cities, and often in somewhat relation to the services that were provided and available there. This was a model that initially served the Minnesota's early expansion populations. It was designed for that. and it primarily still serves the Twin Cities metro area. The partners in this are at the county level, and that's kind of what makes this ACO somewhat unique. The partners are Hennepin County Medical Center, which has since changed its name to just Hennepin Health. Not Hennepin Healthcare, but Hennepin Health. That is the health system partner. And so what really, I think, characterizes that provider system is that it had a number of different ways and models of coordinating and integrating medical, behavioral, and human services, kind of in really close proximity to each other. They tried to take a no wrong door approach, so that no matter where somebody was entering the system or systems, they would kind of find all the services that they needed. They've had a number of different kind of models that they've tried out and have been working on. So I don't want to just kind of pin that on one model of care. But for instance, they had a primary kind of an intensive primary care model, and the idea of in the way that we would think of an ICU. They kind of approach primary care that way, as people typically coming in needing some pretty acute services for primary care because they've been going on without coverage and access for quite a while. This is a population where in our qualitative data, I can say we see examples of people who have had diabetic related amputations because of trust and access and a lot of other issues. This is a population that does not have regular access to care and is very much characterized by that, as well as their very low income. In addition to that, we also have the county Medicaid plan. So I don't know about Florida, but in Minnesota, there are a few counties, Itasca County is another one further north, Hennepin County is one, that among the plans that administer Medicaid, and that's Medicaid managed care, among the plans that administer Medicaid, there are some of them that are run by counties. So as opposed to, you might see Blue Cross or Humana or some of the other larger insurers administering a Medicaid managed care plan. That's the setup. But in some cases, you also see counties, and that's the case here. So this was the health plan, which is kind of a required element for this kind of a model, which is a payment model as much as anything. And then the last thing I would note is that an explicit partner in this was Hennepin County Human Services, which will, I think, be evident for why that's relevant in a second. So the ACO, the workings here is that like managed care, the payment model, the financing for this is based around a per member per month that's a capitated payment system. So in other words, rather than paying fee for service and having those kind of bills submitted to the Medicaid program at the state, we have a managed care organization, again, facilitated in this case by a county, it might be by a private organization as well. But we have a per member per month payment from the Minnesota Medicaid program to that plan. So this is what they get essentially to finance the care for these individuals in this panel of attributable patients. What then happens is that these partners in this shared risk arrangement, that is the county health system, the county payer plan, and county human services, they share in the two-sided risk, that is positive risk and negative risk. So if they can deliver care essentially for less than the per member per month payment, that's a savings to the partners. Those savings are shared among the partners, and often in a lot of cases, we're actually, especially early in the program, we're reinvested into the program for things like quality improvement. So the savings are not just kind of financial savings that people are jumping up and down about for money in their pocket. A lot of these are reinvested to include evaluation services as well as quality improvement. But of course, on the other side, the negative side of the risk is that if they are delivering care for more than the per member per month payment, they have essentially kind of gone outside the capitated payment that's allowed to them, and therefore they are taking on the costs that exceed those provided, the funds provided by the per member per month. Up until a certain point, around I would say 2014, 2015, they were looking back and finding savings internally, but there really hadn't been any comparative study. That is, comparing it to see if it was this model of care was actually better than anything else. You can find internal savings, but is it better than anything else? So the comparative evaluation here, the design was that we would take Hennepin Health versus other Medicaid managed care plans in the metro area. Again, the county plan is a managed care program, which is, in other words, an organization taking on the administration of a per member per month financed set of patients. It's just the difference with an ACO is that there's that partnership with the provider and other partners. So this was taking Hennepin Health versus other Medicaid managed care plans in the metro area. Most of the data, at least for this part of what I'm talking about today, most of the data for the evaluation came from Medicaid administrative data. So most of the things that you would look at in terms of outcomes are going to be healthcare use. We're not necessarily looking at worsening of conditions and things like that you would need EHR data to track. We did use some EHR data internally to kind of do some methods work that I'll talk about in a second, but it was primarily administrative data in Medicaid. And I would say that we got a unique cut of Medicaid administrative data. In other words, we got it from the state as opposed to going through the normal kind of federal approach. The state, of course, being the administrator of the Medicaid program for Minnesota. And so we did get a little bit of information that's a little different and a little bit richer maybe than what people who are getting data at the national level would get. So a little bit, let's say, supplemented Medicaid data. We did do a whole qualitative aim as well, including what's called fuzzy set qualitative comparative analysis, which is really cool and nerdy, but I don't have time to talk about it. But we do have papers on this. Down at the bottom, you can see we published 2 papers side by side in Medical Care Research and Review. So if you're interested, please go there. This study was funded by the Commonwealth Fund. I was the PI, but I do want to definitely highlight kind of who I consider to be my co-lead in this project is Dr. Catherine Diaz-Vickery. Kate is a clinician researcher who is located in Hennepin Healthcare Research Institute, and is also involved in healthcare for the homeless in Minnesota and Minneapolis. Let's see. So the first problem in this evaluation, to get into a little bit of methods, the first problem here is time varying confounding. So we have a case where our enrollment, this is our main exposure or treatment variable, enrollment in a program, the outcomes that we're tracking, so things like emergency department visits, and the confounders that we would want to control for, things like homelessness and other things, those change status over time. So that arrangement that, if you can look at the figure, the arrangement that we would typically show somebody in like a directed acyclic graph or a DAG to represent confounding, those things are actually changing month to month at the very least. So we have this issue where, as opposed to matching everybody on propensity scores at a given time, we actually have to deal with this fact that we're actually tracking people across several months of data with these things all changing at different times. We did have some non-time varying variables, but a lot of things did change status. And so one way to approach the idea of time varying confounding, which is not necessarily just done with kind of a regular regression model, is what's called marginal structural models. By the way, marginal structural models are not new. I remember hearing about them in grad school, but I would say that one of the biggest things currently that allows us to do these is computational power. That'll be clear in a second for why that's important. So marginal structural models use inverse probability of treatment weights. That's a lot of words. So weight is a multiplying factor. You take an observation and you multiply it by something. What is the something? So the weight in this case is based on the probability of receiving the treatment that you're in. So if a person in Hennepin Health had a very high probability of ending up in Hennepin Health, they would have a very high probability. In the same way, if they had a very low probability, if they were likely to have been in another program and somehow they ended up in Hennepin Health, they would have a very low probability. What we want to do is we take the inverse of those, 1 divided by the probability. What that does is it means that if you had a very high probability of being in your group, you're going to get weighted really low, and vice versa. So you can imagine if you look at the figure over here, you've got the tails, the negative tails of each of these groups, where the lighter colored group is the kind of comparison group. This isn't from this particular evaluation. This is just from ARC. But you've got a figure where you've got a distribution of the lighter colored kind of pinkish group. That group is heavily rated, probability wise, heavily down toward the 0 end. So they had a lower probability of being one. and then the higher probability at the other end, and vice versa for the other group. Now, those circled areas are low probabilities, and so those are people who are not representative of selection bias, of treatment selection bias. They're not representative of confounding. They're the opposite of confounding. They're people who had a low probability of being in that group, but ended up there. That's the opposite of confounding. So we want to upweight those people. We multiply them by more. Those people have more weight, and therefore the people who are in the larger part of the distribution, the bulk of the distribution, those folks end up being weighted less. What that does is it helps to counteract the confounding. If we assume that confounding is driving people toward the larger part of the distribution, we're counteracting it by offering our inverse weights. What that ends up doing in practice, when you actually look at it, is you end up creating a pseudo population in which bias does not exist, at least as long as your model assumptions are held. So what we're trying to do is approximate a randomized trial with observational data or retrospective data, which is what a lot of statistical designs do. In this case, because of the time varying confounding, that's what we're trying to do with this, is take our observations and weight them up or down to counteract that. What it ends up doing, though, is that you're kind of creating a pseudo population or a false population, but it's to derive the estimate from that population, because the point is the estimate. The point is not to create the accurate population. We already know that. So instead, what we're trying to do is obtain an estimate. Another key problem in this, and one of the key assumptions of that model, is that we don't have any unobserved confounders. In other words, if you leave something out, you've got unobserved confounding, which increases the error term. It also greatly increases, if it is a true confounder and you've left it out, that means we have predictors, including which plan you're in, being correlated with the error term, which is called endogeneity. It's a key violation of most regression assumptions, definitely in this case. So one of the key things, anytime you're using a regression approach or a propensity score matching approach or a weighting approach, is that you need to make sure that you're accounting for your important confounders. So one of those that I would just draw attention to is homelessness. Homelessness is really a big characteristic, a characterizing feature of the Hennepin Health target population. We knew that it was going to be highly kind of concentrated there, again, with Minneapolis kind of being a magnet for those services. And so if we're looking around at the rest of the metro area, that does include things like the urban core of St. Paul as well, which is right there across the river. But we know that homelessness does end up concentrated there. And so we needed to be able to account for that. The way that we went about this, the issue is that there are diagnosis codes, of course, for homelessness. There's also a homelessness flag that usually gets added into, I guess, most state administrative data in one way or another. The problem is that they are incredibly undersensitive. They don't pick up who's actually homeless. So what we did was we worked on, one thing that we had that a lot of researchers may not have is addresses. We had addresses that were listed for enrollees. In a lot of cases, those addresses were things like churches. In some cases, a box, a post office box or something like that. A general delivery address, those kinds of things. And so what we did was we took those and used them to create an indicator of likely homelessness. And we validated that against an EHR-based kind of a social determinant screener that was used at Hennepin Healthcare. It wasn't necessarily applied to everybody, so it wasn't an exactly perfect validation set, but we had quite a few people where we had both these claims data and this questionnaire that they filled out. And so we did a lot of validation work to kind of show that if we could include this address-based indicator of homelessness, that is our primary way of identifying homelessness. And again, addresses can change per month. So this is still something that we can find and use in our models, but it was the best way we had of doing this. I don't think it's great, it's perfect, but I think that doing the kind of due diligence to make sure that we accounted for this variable was really important. But so that was another, I think, big challenge, and we ended up with an article in HSR for that. That was, again, nice and nerdy. So the findings here, the first thing I wanted to draw attention to and be very upfront about this is that actually in most of our findings, and I'm going to talk about this in a second, my guess is that there's still some residual confounding, and also the way that we specified the outcome variable, the exposure variable. We specified the exposure variable as being enrolled in Hennepin Health in a given month. And if you think about how people work in programs and how programs work, we could have specified that as, has somebody been in Hennepin Health for 3 months? Had they been in Hennepin Health for 6 months? And we did try some of those, right? We also didn't look at trajectories, which I don't have the figures here, but I might have them in the archive at the bottom, but the figures actually show that the trends were very good looking for Hennepin Health. But when you take the overall, there was such a difference in kind of the overall and especially early points that even despite all of our weighting approaches, when you took this across the entire potential denominator, that is people who are in managed care programs in the metro area, again, still accounting for all these other things in our models, and I do have all the covariates listed at the end if we want to look at them, all kinds of things in terms of diagnoses and homelessness, and I mean, risk adjustment using multiple risk adjustment tools, all kinds of things. We still found fairly significantly more use in Hennepin Health. So the idea here was that Hennepin Health should kind of lead people to hopefully use some of these acute use categories a little less. And that's not what we found. We did find significantly higher in a lot of cases, except for dental, which is something that we wanted to pay attention to because hopefully we're hooking people up with services. We don't necessarily want fewer dental visits, but that's what we did find here. Again, the trends showed something a little different, and this is across a very wide population. So we do think there's still something there to this model, but in terms of doing a comparative evaluation, I would say that yes, it could be that there's no benefit compared to any other managed care model. The other thing I would say though is that we had a protocol and we stuck to it, which was again, the way that we specified our exposure variable could make a difference in the answer that you get. Also, I'll just bring this up now. The real target for this model, at least early on, was high utilizers. And we term high utilizers, you can see at the bottom, but these are people who had at least, who had more than 4 emergency department visits or at least, I think more than 2 inpatient stays over a period. And so these were people who were typically routed to some of the special models for care that I had mentioned. You know, a lot more follow-up and things like that in the provider system. So this really was what the model was built around. This was a planned subgroup analysis. In other words, this is not an a priori analysis that we added because we didn't find something significant. We knew this was going to be an important group. And in this group, we found what we would really be looking for with this kind of model, which is, we still find an interesting thing with fewer dental visits, which I don't want to get it. There were some pieces of this that were related to dental. But the big thing that we're looking for is a decrease in inpatient stays. That may seem kind of small, but I think it's easy to miss the magnitude of cost that inpatient stays account for. It's very typical, and I've seen this in other programs. So Minnesota's healthcare home program, which was a patient-centered medical home program that Minnesota instituted. I saw it there as well. You'll see actually when people who have not had access to care start getting care, you'll probably see increases in emergency department visits. And that probably is to be expected. We should build models around that. Because if people are not used to or not able to schedule care, get in with regular primary care visits, where are they going to go? They go to the emergency department. So it's actually not necessarily a bad thing in my mind to see increased emergency department visits. They're not always that expensive. The things that are expensive are inpatient stays. And they are incredibly more expensive, such that you can have many more primary care visits and many more emergency department visits. And if you can stave off just a few hospitalizations, you'll actually still save money. Sometimes, again, if these programs are instituted on a large scale, you save a lot of money. So this is more what we would want to see from this. And again, this was more of what the model was originally designed for. But again, in the evaluation, if we look at the overall, and this happens when you do evaluations, if you look at an overall group, the effect tends to get washed out or is brought in different directions. Because again, the whole group is not necessarily what something's built for. So Overall model actually found no benefit or higher use, but among this kind of target group, which was again a pre-planned subgroup analysis, did find kind of the more intended effect. So the takeaways here, I just want to note the limitations stemming from existing systems. We didn't have a lot of outcomes that we would have wanted to study. One example would be that the care models that were built for in this plan, the care models that were built for this were also designed to get people hooked into a primary care team. So one way to study that would be something like care coordination. Now, usually when you're studying care coordination using claims data, you're trying to see, is there a certain concentration of visits with a particular provider? How do you identify providers? You identify them usually with individual provider NPIs, National Provider Identifiers. The issue with that is that at least in Medicaid data for that period, and it's still definitely an issue in certain parts of administrative data, organizational NPIs. So whether somebody's seen at a particular health system, those are filled in, those are available. You could technically look at that. That's not really what we were trying to get at, but you could. The problem is that individual provider identifiers, how we would actually find, is this person seeing the same doctor? Those are not filled in with any regularity. So in other words, the data system itself was kind of limiting in terms of the types of outcomes we would have available, even though this outcome was something that you would presumably identify with administrative data, the fields just weren't filled in. Because again, usually that's not how things are built for. And so it becomes less important. The other thing I would just note is that, I mentioned that this group is highly prone to less enrollment during a potential observation period. And disenrollment is a big issue with this, with in particular this early expansion group. I can say that definitely complicated all of our analyses. To give you an example, the way that we usually identify something like a diagnosis for, it could be mental illness, it could be something like schizophrenia or schizoaffective disorder, or it could be something like diabetes. We usually identify those with diagnosis codes from the claims. When we use diagnosis codes from the claims, we are usually using some standard period of time, like 1 year of data. Well, we don't have 1 year of data on a lot of people because they're only enrolled for 3 months at a time, 6 months at a time. So the very fact that the system could result in people kind of being disenrolled with some regularity actually complicated how we would ascertain these types of variables. Now, in our weighting scheme, in our marginal structural models, the way you account for the censoring that happens because of that is through a censoring weight. You actually add a different weight that is based around people who are likely to drop out. Right? And so if you're going to do that, that means that if somebody's really likely to drop out, you want to weight them up because those are the people that you don't want to miss. So if they were likely to drop out and didn't, you want to see them more. The problem is that if somebody, imagine, is really likely to, or really unlikely to be in their group, and they are also really unlikely to be in the data, we were weighting them up in both cases, and weights, when you create the weight, they start to expand very quickly. And so you end up with people with incredibly large weights, which is one of the key problems with the weighting scheme, as opposed to matching or other things. People with really large weights can swing your results with just a few individuals. Because all of a sudden that individual isn't one person, they're 100. Right? And so what we ended up having to do, and they're different, this is more of a theoretical argument that you could have, is whether to truncate weights or not. Now, we truncated them out to like the 99th percentile or something like that, because that's kind of what the weighting scheme is supposed to do. But the estimates become really unstable. They're very prone to like big changes based on really small changes in the model. And we don't have a lot of confidence in models if they're operating like that. So we tried truncating the weights. That's, I think, the main analysis approach that we took, but we did put all of our sensitivity analyses reported in there. But that was another, again, this is, if you walk this backward, this is all based around existing systems of how people are enrolled and thus how they end up in the data. Right? So these are systems driving some complexity in this. The other side of this is that we have to really consider the population when we anytime we're interpreting results, we got to really consider the population. I have to remind people of this a lot when we look at Medicaid, and particularly Medicaid expansion. Things in this group mean something different than if you're talking about a Medicare population, an aged Medicare population, for instance, or a disabled Medicare population. These early expansion enrollees were early expansion by virtue of not being disabled, not being aged, right, and not having children. Right. So in this group, they're characterized, their social complexity comes from a lot of things like sometimes I've seen some other work indicating like issues with executive functioning, being able to kind of get through life and stay organized and things like that. And a lot of that stems from early trauma. Right? So this population is characterized by some things that we are never going to touch with a study that's using administrative data from Medicaid at the current time. These are things that exist in long cycles, usually lifelong and multi-generational. Right? So this is something that gets built up. And so one of the things that we want to think about is, these high utilizers that are the target group that end up in acute care because things weren't taken care of in primary care. They have stories. And we've seen these, and again, I can't get too much into the qualitative data, but we've seen these stories of trust broken by providers. So this isn't just kind of faceless systems, but trust broken by providers. We've seen, again, stories of having children removed from the home. I've done some work on out-of-home placement of children in its population. A lot of like really tough events to live through, right? And so what does that mean when that's a high utilizer, right? So how we interpret these results, I think we need to really take things into context. The other thing I would just note is that, again, I kind of made this point, but we want to think about, is less care the goal? Because a lot of times when we're looking at programs like this, we're trying to reduce costs. And we say, we want less care. Not necessarily for this population. Almost certainly not for this population. Hospitalizations, yeah. Avoidable hospitalizations, however you want to kind of create those out of the data, absolutely. But emergency department visits, that's how this population mostly accesses care. They're not used to, they've never been covered by insurance. How do you navigate that, right? The only way that you know to access care, the only way you've ever been connected to is to be able to go into the emergency department. So it's just something to kind of think about. If we're giving people the idea that they can access care and get their problems taken care of, and the only way they know how to do that is the emergency department, do we really want to say, well, we want to reduce emergency department visits? Could we create systems that are more welcoming and other things? Yes, but that's not on individuals, that's on systems to provide alternatives to the emergency department that still look like the emergency department, which we don't really have. The last thing is that the challenges are interacting and stability is really hard to find with this population. So before I go on there, were there questions about this project because if there's any methods or other kind of questions related there?
Can you hear me okay?
Yeah.
Okay, so we actually have a question from online. Tyler, do you actually, it's such a long question. I thought maybe it might be better for you to just unmute.
Yeah, I'd be happy to. Can you all hear me?
Yep. All
right. Well, first, I did not know that my audio was on to begin with. I'm sorry if my clickety clacking was disturbing y'all. Or
No, it wasn't.
No.
Well, whew, that's relief. Anyways, well, first, thank you for being here and presenting this really valuable information. I will try to condense my question. And generally, what I wanted to hear your thoughts on are when you're examining these types of measures, the nature of measuring utilization and claims and encounters, there is a challenge of how you define something as utilization versus a health event. And so I wanted to hear your thoughts about how you interpret findings as utilization versus a health event. And the context is, I've been doing similar work recently on a temporary housing program, and we had a similar issue, or not issue, I guess, a challenge of how to interpret, certain types of encounters like inpatient admissions, psychiatric hospitalizations, ED visits. And while we did see increases in those incidents, we also saw a decrease in mortality. And so that led us to try and interpret these findings as more of an uptick in utilization because of increased contact with the healthcare system and people who understand the healthcare system, which could have translated to lower mortality.
Yeah, no, that's a really good point. So one thing to keep in mind also is, again, we were this was a big project that we had a lot of programmatic partners as well. And so one of the things that we were looking at is what was important to the people, the partners that we had to show for this model in terms of its benefits. And for them, being programmatic in their focus, they want to see, are we doing the things that health systems and legislators and other people want to see? And so for them, looking at utilization, and it was kind of visits of this type, kind of counting visits and things like that, really was what they were paying attention to. But your point is really well made in the sense that I don't think that those are great measures, actually. And so there was a lot of kind of maneuvering early on and discussion early on in this project, but we did stick to the protocol that we set out because we felt that was important. And we had a lot of method sticklers on the team too, which, no, I think I'm one of them. But your point, I think, is really well made in the sense that these are not necessarily great measures. And would I look at, especially, you got to consider the type of data we're using here. So the way that you could look at this is you could look at incident events of certain types. So, myocardial infarction, strokes, certain things like that. You could look at specific types of acute use and things like that. So you could look at specific events. There's a little bit of challenge in identifying incidence versus prevalence. So if it's something that is a condition that could be still coded for long periods of time, which does happen, you'd have to be wary of that. The other thing I would suggest, though, is probably the thing that I might go to is there are a lot of ways that people have used to identify preventable or avoidable use of this type, and that is for things that should have been, primary care sensitive conditions is one set where you've got a number of conditions where if somebody has a hospital visit for that, it should have been gotten to before. Now, whether that's used to like blame primary care or something, I don't think is necessarily relevant to that. But I think there's those, similar with there are other types of preventable that look at the types of codes that are used in the emergency department. Because there are different levels of essentially kind of similar to E&M codes that are used in the emergency department. So trying to kind of at least bring these outcomes that are utilization outcomes into alignment with a little bit more of what we would hope to see, I think is important. And also, again, not always aiming for lower counts, I think is important. But yes, I think your point is well taken. I don't think there's an easy answer to it. I think my go-to has been to try to fine tune, add some nuance to those utilization outcomes, including things like avoidable.
There's one other question, if you have a minute to, before we move forward. The other question was, for high utilizers, how much of the reduction in hospitalizations was accounted for by fewer persons with severe or persisting mental illnesses being admitted to psychiatric hospitals or units? And the reason for this question was the possibility that other things at the level of policy or newer supplemental resources may have accompanied Medicaid expansion and HH establishment, confounding by co-intervention.
Co-intervention, yeah. So first of all, I think the point of how many of the fewer hospital visits are accounted for by was it mental illness?
Yeah.
Yeah. We didn't look at that. It's a good suggestion, I think. I can say that the picture that I get described to me, the picture that I saw in the data at least, was not necessarily one where we saw a lot of that. In terms of co-intervention, I am not aware of something that was programmatically or policy-wise really changed around that time. It's possible that the effects of something were taking shape there, but I'm not aware of anything. It's a good point. It's not something that we looked at, but again, we did have so one of our main partners was since Ross Owen, he was the county kind of plan administrator, the program administrator for the plan, was on our team. We had a number of people from the county involved, and quite a bit of discussion. I don't remember any of those coming up, so it's possible. It is possible, totally possible. And I think there is always a chance for some residual confounding. I think there's definitely residual confounding here, no matter what. But nothing that I'm aware of, and nothing that our program partners brought up when we were talking about things we needed control for. So yeah, I would say that this kind of payment and delivery system change had a lot of parts to it in the system. So it could be that some of those things they consider to be folded into this model for individuals. The other thing I would just note is that a lot of things are administered at the county level in Minnesota. That's a little different than some states. Some states, counties don't have quite as much kind of federated sovereignty or whatever you want to call it as in Minnesota. There's a lot of county administration of programs. And so to the degree that policy or things were changing, it's just as likely that they were changing in St. Paul, which would have formed at least some chunk of our comparison group. So I, again, can't identify something could have happened on the other side, but it is a possibility. And again, there's very likely residual confounding here. All right, so we're probably gonna have a ton of time. I don't want to take the entire time, but I do want to get into this a little bit. So patient complexity, I just want to bring this around to a little bit more of a higher level of abstraction and theory, because that's how I spend my time, so I'm going to make everybody else do it too. So patient complexity is it's a way of framing challenges. So we got a lot of different ways that we can frame the challenges that characterize populations. In this framing, different factors shape the relative complexity of patients. So it's kind of this underlying thing that people describe differently. But it makes things harder to anticipate or predict, and therefore harder to manage. So it adds uncertainty and unpredictability in particular. But again, it's a wide concept. It can include both a potential kind of Medicaid patient, somebody who's sick but really lacks access and low income and some of those things, versus a patient who might be seen by this was kind of, at least in the Twin Cities metro area, this was brought up a lot, is that there's this typical like Mayo Clinic patient, because it's in Rochester. I used to work there, and so that's actually where some of my work out of this came from, where somebody's sick. Really sick, got a lot of comorbidity, but they're worried, but they're also worried by their kind of overtreatment. Both of these can embody patient complexity. I've seen patient complexity applied to a lot of things, right? But the result, I think, is the same, and I think that's the main point here, is that patient complexity, when people apply that, they don't necessarily mean some larger complexity theory, although I usually do. What they really mean usually is that we're not getting the outcomes we want or expect. We're not getting the outcomes we want or expect. It's that unexpected, uncertain nature of things that ends up happening. And the other side of it is that in addition to that problem, it's not the resources we expected to have to spend on this. We have to spend more time, make more connections, use up more costs to get to the outcomes to try to get to the outcomes that we want. So to me, that's kind of really what characterizes complexity, is something like that. So some people have approached this by what I would call kind of a bucketing exercise, where essentially we're naming and kind of typing complicating factors. Right? I don't see this as that different from just calling something social determinants of health, or whatever term you want to use, right? You're just calling it something. Unless you're kind of maybe you're building a care model around this or something, I see this as a fairly descriptive exercise. I don't know that naming things a particular thing necessarily gets us to where we want to go. Now, could it be useful? Yes, but I have seen a lot of models that do this kind of thing. But we have a need for mechanisms. That is, the dynamics that actually connect things to outcomes. And that's why I love this quote. This is Willem de Kooning's abstract expressionist painter. The trouble with being poor is that it takes up all of your time. It's the second part of that that's the mechanism. We don't just say, oh, it's low income. It takes up all your time. Why? Think of a dozen different ways. You don't have a car. You don't have childcare. You don't have home internet. Right? You have to arrange your life around things just to make it to a visit. Right? It takes up all your time. That's a mechanism. So this is what I came up with quite a while ago now, while I was still at the Mayo Clinic originally. Is a model that's focused on dynamics. How do things enter the patient experience? And I don't have a lot of time, but to kind of boil these down, problems, complicating factors, homelessness, not having a job, not having low income, not having a job that lets you get into visits, all kinds of things. Those enter the patient experience through one or another way. The first way is that they add to the patient's workload. Everybody has a workload. So the point here is not that patients have workload and we don't. Everybody does. But being a patient adds to your workload. So does being a parent. So does having a job. We all have a workload. The difference here is that something is adding to that person's the work that they need to do. And the way that I think of this, the way I usually say it, is that it takes up your time, energy, or attention. You got something that does that, you got more workload. The other side, the other things that, so you can imagine a really complex, medically complex patient who has a lot of self-treatment demands. A lot of pills they have to take, things like that. That's your workload. That adds to your workload. The other side of this, though, if you want to think about if that's the Mayo Clinic patient, the other side of this is the Medicaid patient, right? Somebody who does not have a lot of resources to bring to bear to make that workload manageable. So to me, this is about an issue of balance. Can you balance between the two? Are you in balance or out of balance? And again, you can think of a lot of different ways that this could happen, but just imagine where somebody faces both. They have functional limitations, and they're given a lot of self-management tasks to do at home after, say, a hospitalization. But that's not the end of this. The other things that happen here are those things imbalance, and they create issues around things like access. Regular utilization, so regular access to care as opposed to needing to come in for just an emergency department visit, right? Adherence to self-management plans, right? Those are the kinds of things that we see disruptions in. Missed appointments. To me, missed appointments are like one of my favorite things because it's one of the perfect examples of this. You set an appointment, you set work. Presumably the person agreed to it, and it didn't happen for some reason. Didn't have time, didn't have a car, whatever. But those things happen. And then in turn, all of that, including the stress that comes from managing workload and other things, all of that drives health outcomes, all of it. Right? And again, the focus is not on naming these things, it's how. It's the dynamics of the model that matter. That's why the particular mechanisms that I'm naming are kind of basic. But again, it's not kind of the end of the story. The other problem is that unless you're talking about death, every outcome has consequences. Oh, you have a hospitalization? Guess what? You're going to be sent home with self-care instructions. Adding to the workload. And presumably, you are also not feeling your best, so lower capacity. Now what happens when I'm sent home with self-care instructions that I don't understand because I have low health literacy, or because I'm not feeling well and I don't have a caregiver? We compound this problem. So the real worry that I have here that this model indicates is cycles of complexity. Again, unless you're talking about death, everything is going to happen. Could happen. The other way to think about this is if we're going to intervene, what can we do to break those kinds of cycles or to disrupt these dynamics? So if we're going to intervene, if we give a patient a lot of education materials, technically, what are we doing? First of all, most directly, we're adding to their workload. So the question then becomes, and everything we do for a patient, that we do for a patient, is adding to workload in some way. You give them more pills, well, now I need to remember to do that. You provide capacity coaching, whatever it is. The idea, though, is yes, everything requires some initial investment of work. Does it pay off? Is that an investment, or is it lost resources, lost work? So it also means that we need to be very finely tuned to where patients are at and how things fit into their lives, so that something can be an investment as opposed to wasted time, effort, and attention. This has been, I think that I've already mentioned like kind of what the contributions of this are. The main focus being that it's a dynamic model, that we think about cycles, and that we want to think about how, if we're going to intervene, these kind of net balance idea. It's been applied to a lot of things. There's some people I know and some people I don't know who've used it in their training grants, NIH grant conceptual models, patient indices. I've seen somebody build a complexity index, stuff like that using this. It's useful as a qualitative coding tool. In terms of interventions, these are the ones that really make me happy, because I read about some study that I was never involved in where they said, oh, this is based on the cumulative complexity model, and we reduced falls by blah, blah, blah. And I was like, okay, it's a Friday, I'm done for the day. You see these things, and it's really heartening because I'm a sociologist originally, and you don't really expect to impact the world very much, so. So it's, you know, no, it's also, you know, I consider myself a reformed sociologist. But no, so it's, you to see impact, I think is really valuable. The one thing I would note is that some colleagues at the Mayo Clinic did a systematic review looking at, I think it was cardiac readmissions, and found that interventions, they coded these interventions in the systematic review, found that if you support patient capacity, your intervention actually does better at reducing readmissions. And a lot of times we're not necessarily thinking about supporting patient capacity in that way. I think I'm just about done. I think we still have. So what have I learned in kind of working with this model? I've been involved in some projects where we've used this. One is that complicating factors affect outcomes by multiple pathways. There's no simple dynamic. So those arrows that I was showing, if something impacts something along that arrow, maybe it's in multiple ways on that one arrow, or maybe it's through some other direction. An example I would just give is homelessness, because we've kind of harped on it a little bit. So homelessness, in some qualitative work we've done, we have people who are not just unstably housed, but fully kind of what we think of as homeless, stereotypical homelessness. You'll have people who they don't have anywhere to go during the day. So they don't have a job, but they also can't stay at the shelter. They're not welcome in certain places. So they have to fill their day up doing something. So you might see somebody riding on public transit. They're not necessarily like there to take up space and annoy you or something like that, or for you to get angry about or say, how come that person's staying past their pass or whatever. Actually, they may be trying to fill up time, energy, and attention. Separately, there are a lot of capacity issues that come with homelessness. So one example is sleep, which a lot of people don't necessarily think about. Trying to stay, especially if you're talking about shelter, there are other types of temporary housing and other things, but if you're talking about shelter programs, sleep sucks. It's really hard to get a good night's sleep. And a lot of the folks who are trying to manage their healthcare conditions are, you know, say in their 30s or 40s. One thing to note also is that this population tends to age prematurely. So somebody who's 30 might look 50 if you're looking at their health indicators. But they're trying to manage conditions, and meanwhile they can't get a good night's sleep, or they don't have anywhere to put if they're on insulin, people steal it. It's a needle. Sell it or use it. It's insulin necessarily. Also, they might need a fridge to keep their medications in. Things like that. So there are capacity issues. There are also workload issues. It's not a simple thing. It's not like, oh, homelessness, that's a workload issue. No, it's both. So there's no simple dynamic. These are multi-path dynamics, which makes sense since we're talking about complexity. The other thing I would say, one other thing is trying to measure everything doesn't work. There's too many things. So usually when people bring me onto a project and they say, hey, how do we do complexity with this thing? Usually what we try to talk about is, how do we target down to this population? What are the main things that affect workload for this population, for this group? They're not always the same. So that's I think targeting to the population is I think important. And the last thing I would mention for this is that the models and thinking are still individualistic. We're still focusing on, is this patient complex? And that's definitely my at fault as much as anybody else's at the time that I wrote this. But since then, I've tried to draw attention to this, which is that complexity grows from systems. And this is, you know, kind of my eureka moment was realizing that the stuff that I was doing in quote unquote complexity was not really complexity, but there's a whole field of complexity science and complexity theory. And that can become your hobby, by the way, if you really want to get lost in people writing about complexity theories, and you like, you know, pretending to have your mind blown and stuff like that. Go ahead and read all that stuff. But I think there's some practical things we can think about with complexity. So I had some slides where I was going to just like say, here are the functions of a complex system. But we're not going to do that. But what I will say is that, first of all, that a complex system is everything. Right? Danella Meadows is a population researcher, has a really good book on complexity and systems, and writes that every person we encounter, every organization is a complex system. And I would just say, if it's got people in it, it's a complex system. Human body, family, job, Medicaid program, hospital, everything. And the complexity grows. The things that what makes it complex is things like things being interdependent, by which we mean very interrelated. You've got multiple interactions going on. So it's not homelessness and mental illness, it's homelessness and mental illness. Their combined effect, which is also depends on the effects of substance use, right? For instance. So it's these interdependent relationships, which happen when you've got a lot more elements bumping around, like the bees in a hive, right? When you get the more elements you have, and the more different they are, the more they bump into each other. And so you've got a lot of interactions going on all the time, and you can't watch them all, right? And so this is where I think it's important to realize that it grows out of this model where it's important to talk about people with many intersecting challenges, because that's how it happens. They bump into each other in ways that we can't watch or identify or predict. And that's related to some of these other program characteristics. One being that things are emergent. They are unexpected. Things emerge from the interaction of these things on their own. We didn't design it that way. Nobody intended it that way. It just happened. One example of this in public programs is unintended effects. We've had qualitative work with these with folks in this population where they wanted to get a job, but they've heard of people losing their benefits in different programs because they made too much money. So the minute that you start to get your legs under yourself, you get knocked over again. At least that's the picture that people get. That's their lived experience. So one person said it's hard to get off the merry-go-round. There's no off ramp. That's tough. Now you can do things programmatically to help that, right? But it exists, and what that all kind of results in is that things are uncertain, vague, imprecise. So if we're trying to plan things, if we're trying to design things, it's really hard to do it well if we assume that we need precision. And that's what a lot of times what we're going for. We want these like tight point estimates. We want exact estimates of how much this is going to reduce hospitalizations, things like that. I'm not going to get into this part. I think I'll probably end here with this. One of the things about complexity science is that we talk about metaphors being useful. So the metaphors here, the one I would lead off with is farming. And the story I usually tell is that I heard a farmer on National Public Radio talking about something that was going on for that particular season. Think about that. They're thinking in terms of seasons, market. They got to think about the market, like what are the prices right now? And they were talking about weather. Those things that farmer cannot control, right? That's multi-conditional uncertainty that farmer lives in. So what do? Well, they plan ahead. They produce conditions that are conducive to good growth. So rather than aiming directly at the target, directly at some desired outcome that we want, what if we thought about creating the conditions that are conducive to growing that good outcome? What if we grow outcomes? That's again one of the things we want to think about is don't think about things as lifeless. Everything's alive. Right? If you think about things as complex systems, everything's alive. And that's my second point, is think about things like living organisms. The Medicaid program is a living thing. It's a living, breathing thing. It gets sick, calls for help. And it's the same way when I talk about, so the ResDac that the director is, I think of our organization as an organism. I think, are we healthy today? I haven't seen anybody talk about it. I should probably write a book on that one because I don't think I've seen anybody talk about that as much. But what can you promote habits for a healthy organism? Think of it as a living thing as opposed to, well, we're going to move this part into here and here's our structure. You can do that, but you're probably going to be led into places where you've overplanned, where you planned in the wrong direction, especially overplanning in the wrong direction, where you're not ready for things to change. Well, I want an organism that has like healthy joints that can move around. I want an organism that can breathe well. And so if we think about organizations like that, if we think about programs like that, interventions like that, we're going to understand that these things grow. They grow and mature. An example is maturity models is one way of designing change in systems. So I'll probably stop with that.
Are there any additional questions?
Actually. Well, thank you so much. as someone who works with community partners, and given our current political climate and also just the way that legislation is made and things like that, regarding kind of the economic cost of everything, how do you approach, especially giving things like these systems are kind of, you need to build these systems in different to account for complex needs and things like that. How do you work with community partners to kind of like necessarily move beyond just the budget or the economic like cost of what this is? Because again, it's so complex, and maybe you might see there's some risk with you might save some money here, but maybe not save some money there. But again, a lot of times legislation is made regarding specifically what are the economic costs and what do you get out of it.
Yeah.
So just as someone who works a lot with community partners, how do you kind of move beyond, or how do you work with them to talk to them about like it's more than just the economic cost that's here?
Yeah, well, so it depends on who who your audience is, I think. So one thing is if you're trying to communicate to those people who are assuming that it is about the costs, right? I think speaking in terms of investments and some of that kind of thing, if you say, well, this is kind of a losing the forest for the trees, or you can kind of say like, the return on investment on this is going to be poor, and some of those kinds of things. So I think talking to those audiences, I also think that talking to those audiences in moving away from a very myopic view or a very closed scope around the targets that they're aiming for, and say, yes, you're going to hit this target, but it's going to cause these other things. And if you can still get that into their language, sometimes that's motivating. As far as working with the community partners and how to kind of navigate that and build things, I guess, if you think from an organism metaphor, if conditions get hard, one thing to turn to is your relationships. You can lean on your family or your friends or whoever. And if you kind of use that as a metaphor, then what does that mean in terms of how community organizations can weather storms like this? And again, we think in metaphor, right? So I guess the things that I would naturally go to are, have we built up a healthy, when things are fine, have we built up a healthy set of relationships so that when storms happen, we can at least make sure everybody gets shelter even if it's not great. I think that paying attention to what is important to your partners also means that you identify early on and build into your intentional kind of designs the priorities for the people you're working with, as much as the kind of higher up stakeholders or somebody wants to know the costs, and say like, well, we have a set of targets here that, we got some cost things and stuff over here, but also what we're hearing from this group is that what they really need is this. And we've done an example would be like qualitative work we did in a similar population. This was looking at well, I guess we could use the example of work history, that study. Individuals in that study found a lot of ways to make things work, even though the minute that they paid, they're pretty low co-pays on medications and bought a little food or something like that, even if they were in temporary supportive housing or something like that, they had nothing left to like live on or use for anything. And so people found ways to kind of live in that tough situation where they felt like they didn't have an off-ramp and still were dealing with low income. And I think if people were listening, if we were listening to them, one of the things that we looked at was how would things like work requirements and Medicaid, how would that land? And for a lot of folks, it would mean there are very early steps of trying to get into developing work history and those kinds of things. Or if it means fitting in, if the work requirement allows volunteering or school or something like that, how do we fit those in healthy ways when somebody is, again, just trying to kind of like weather the storm that they're in right now? So I have this kind of wide-ranging answer. It's not a great like on-spot answer, but I think that I would think in terms of relationships, when times are a little less chaotic, trying to build those relationships at those times. And I would also say think in terms of relationships. I think as researchers, we a lot of times have a very extractive mindset. this is my study population, this is my target population. Even that's like problematic, right? My target. So instead of thinking about like, can we build relationships long term so that when it's time for a study, when something happens, whatever, that we're not trying to form something in the short term that feels cheap. Yeah. Yep.
There you go. Hi, thank you so much, Nathan, for the wonderful presentation. I apologize, I came a little bit late, but I kind of heard from the, when I came, you mentioned something like the weight patients. I know like in my earlier research studies, I concern a lot about the population representativeness in clinical research. Essentially, when you kind of develop a research protocol, you can recruit patients to a study based on very restrictive criteria. And then you kind of miss people who potentially may benefit from those interventions. You also look at how we use real world data to inform study design. So look at, okay, how many patients are excluded for a particular study like cancer, Alzheimer's, and then we're trying to adjust criteria. So this is part of my earlier studies in this space. And at that time, we mostly focused on using electronic medical record data because that's a typical kind of data we work with from real world. We also have used previously some national survey data like national from CDC to look at the population, the target population. But still, I feel like there's always some biases in the data. You know, there's some famous research saying sicker patients are more dead. I think you also alluded to that in your presentation. So I'm wondering, in your view, like when people are utilizing those type of data sets, observational data sets for analysis, how would you be able to advise them to generate evidence from those data that can form like more broader population, more benefit population for policy, and not really biased towards population that are more sicker?
Well, you got another hour. So I guess, this is one of my hobby horses. So one of the things that I pay attention to a lot is unenrolled months. I think it's a really big blindness that we've built into our studies. So one study, we actually submitted a paper on this. So just to provide an example, submitted a paper just recently on this on really basic look. We looked at, what happens when we do what people normally do, which is if somebody doesn't have 6 months of continuous enrollment, in some cases 12 months of continuous enrollment, they are clean, they're removed from the data. Well, what does that look like when we apply it to Medicaid? And I can tell you that, so first of all, even in that study, we included people who had at least 1 month of data. Now, some of that is because there's some people who might pop in for a day and it's like, it could be administrative noise. But that also means we're already starting off from a potentially biased standpoint. They had to have at least 1 month, which means that there are some people who didn't have 1 month. Now that's like less than 5% of people probably, or something like that, but it does happen. So even in our things, to make things work in an analysis, sometimes we make like choices that are already sticking us off on kind of the wrong foot. But in that study, what we did find is that you definitely bias things, and that's that is an absolutely normal, I would say the norm in analysis using administrative data is to clean data in that way because you need people with complete months. Now there are other ways of handling missing data. And don't get me started on missing data because that's love that area. But there are a lot of ways you can handle missing data, and they all make different assumptions about the missing data. But a lot of times what people are doing is dropping them. That kind of assumes that those people who you dropped, they're no different than the people who are left in. It's probably unlikely. And what we found is that when you drop people like that, at the very least, you are dropping Medicaid expansion enrollees more. You're dropping non-citizens a lot more. We didn't find a lot of things in terms of race, ethnicity, or sex, or any of those things as much as you might expect. But I would say that age groups, because those also represent different program eligibility and stuff. So you might drop kids that are in CHIP more. So kids in CHIP, Medicaid expansion enrollees, non-citizens. There's a couple of other categories, but so yes, that's a methodological choice that doesn't even show up in your final estimate at all, right? And that's just again, that's a choice that's made by the analysts. They're losing data by doing that, right? So I would say there are things like that. The other thing is to not reify what is in the data. The data are a measurement of things, right? And measurements are inherently symbols. It's not the thing. A visit in the data is not a visit. It's a thing, right? And so one thing that I think is dangerous is that you know, we'll ask people questions, we'll give them a quiz or something, and sometimes people, their first answer is that they assume that the pattern, the weird pattern that we see in the data is real. So like there's a comorbidity index where if you apply it because of the way that it's designed, if somebody only has hypertension, they have negative comorbidity. And you have negative comorbidity. Doesn't make any sense. That's because it's the way it's created. And again, if we reify that thing, then we could say, oh, hypertension is protective. No, what it probably means is that if you don't have, this is in a Medicare population, if you don't have hypertension coded somewhere in your claims in a Medicare population, you have poor access to care. Right? So having hypertension listed is actually an indication that you got care that you needed. Right? At least possibly, right? And we don't know, that's the problem. So I think the important thing is not to reify the likely artifacts that we find in data. And if I could give like an overall kind of like recommendation that would cover lots of different examples, it would be that. Just don't reify things. These are things that represent administrative processes, which themselves, right, are not real things. They're things that people have created around real things. A diagnosis code is not a diagnosis. A diagnosis itself is not a disease. So I think there are a lot of ways, if I could, again, give one rule that I would say to follow is don't reify. Just because a code exists for something doesn't mean it's going to get used. Right? People ask me about obesity or smoking. Well, yeah, there's a diagnosis code for it. Would I trust it? So I'd say that's probably in terms of a kind of starting point. I would say is that.
I think we're out of
Probably,
time,
yeah.
unfortunately, but thank you so much for everything, and for those of you online.
It's so she's running like a big, yeah, so I got.
So, I was gonna ask